Hi, I have a request from many of you to have a small video on counseling antenatally when you are expecting an extreme premature delivery. So this is a very difficult subject. Obviously, there are so many factors that influence how you approach. The first and foremost is where you work, what facilities you have, and what outcome you have for the extreme premature babies in your setup. So you'd have drawn up some local statistics. You also know whether you can manage such babies in your unit or you would have to refer them on. You have broad statistics from all over the world. It does vary from place to place. For example, centers like Iowa or some centers in Germany and Japan, they demonstrate 50-60% survival at 22 weeks. Well, most of us would be struggling to have one or two survivors in a year in that category. The 24 weeks onwards, it's more clear cut in most of the developed world. We have 40-50% survival at least, and about 25-26 weeks, it starts becoming like what we used to face with 28 weekers when we were training 20 years ago, for example. So in your region, it depends a lot on facilities you have. For example, if you're in a developing country, the situation would vary a lot. So babies about 25-26 weeks are more realistically saved in those settings. Of course, you get the occasional very tiny baby who is growth restricted, who may survive and do well. So the local constraints needs to be kept in mind. The social factors, the cost factors have to be kept in mind. And if the baby does survive and has significant sequelae, do we have supportive facilities for those babies? So I'll share the link for two of my videos, one on ethics related to extreme premature in the developing countries, and what I think on approach to prematurity. So those two links will be there below as well. So once you come to this kind of picture of what gestation you are pitching at for the parents to be actively managing, it has to be consistent. If your unit is not the best unit, be honest with them and give them the picture of where in the nearby region, especially if they can afford. If the approach will be different in a developed center near you, refer them to that rather than hold on to them. Antenatal steroids as well will be decided depending on your outcome at specific gestation. So in most of the Western world, they start giving at 22 weeks onwards when there is a risk of definite premature delivery at that gestation. Magnesium sulfate, most of us take to 24 weeks and above for neuroprotection. If your cutoff is going to be 25 or 26 weeks, you can discuss with your obstetrician and decide accordingly. In terms of speaking to the parents, the first point is to clarify to them why the baby is at high risk. The limits of viability and the local data have to be presented to them. The clarity on long-term outcome is not there in most of the situations. We can only say there is a 5 to 20% risk of neurodevelopmental problems which are severe, and there is a 30-40% risk of milder problems in the remaining babies. So 30% chance of normal outcome, 40% chance of mild abnormal outcome, and 20 to 30% chance of severely abnormal outcome or significantly abnormal outcome. This applies to the babies below 26-27 weeks. So the neurodevelopmental outcome doesn't change much according to the gestational age. So once the baby survives, irrespective of whether the baby is 22 or 23 weeks, of course the struggle they go through is variable. The smaller the baby, the longer time spent, the higher the risk of complications and so on. But the future outcome doesn't seem to differ much. Once you are an extreme preterm baby who stays in the NICU and survives, the outcome is comparable. So there is not much to differentiate once a baby does well. So be clear about the duration of stay, the cost implications, the impact on the future development. So you cannot categorize the impact, but you can say broadly that it can affect the motor milestones, it can affect the development of the child, performance in school, it can affect the vision, the hearing, and you can discuss learning difficulties and how they would impact the future of the child. Growth outcomes are not easy to comment on at this stage, so better that we don't discuss it till the time of discharge. Of course, we can say the babies may stay smaller, but that's not the major issue. BPD related complications like a reduced lung reserve or increased risk of wheezing, again, unless the BPD is very severe, should not impact your discussion in the beginning. So the focus is on survival and neurodevelopment. And there is a lot of emphasis on local factors, what gestation you would pitch at. Once you choose the gestation, you focus on the neurodevelopmental factors. You assess the parents' perceptions of risk and what they feel of a child with neurological abnormalities. You assess your team's ability, and if there is a gray area, you can tell them that we will be present at the time of delivery and we will discuss as we go on what approach we will take. Of course, the baby's response to the initial resuscitation is important for you to take further. I know this is a complex topic. I've given you an overview of what factors you would consider, and it's not all encompassing. There are many other lectures online as well which deal with the ethics of extreme prematurity, and I hope this is useful. If you have any thoughts, please do share.